slideshow mode?
Yes, yes.
Yes. Okay. So if you try to contextualize the cardiovascular risk in presence of the ASCVD compared to the heart failure risk, we know that diabetic patients, if you look at the ASCVD risk, yes, ASCVD risk, the diabetic patients are either high risk or very high risk as far as the ASCVD event rate, that is myocardial infarction or ischemic stroke, is concerned. A person will be high risk if he does not have any event or does not have many risk factors, but becomes very high risk if he already has an event or multiple risk factors, where our LDL goal also becomes a little quite lower. But at that stage also, the overall risk of mortality is between 1% to 7%. Compared to that, if patient has developed heart failure, he is at a very significantly increased risk of mortality, starting from 10% to 40%, depending upon the status of his LV function and status of his therapy, whether the patient is responding to the therapy or not, how frequently he is needing the hospitalization and all that. Which means that if the patient is taking multiple guideline-based therapy for heart failure and still not responding, his risk of dying in next 12 months becomes or remains very, very high compared to the ASCVD event rate, where you can do a lot of other things, including intervention, to save the patient's life. And that's why heart failure is much more important than a cardiovascular event of an ischemic origin. And that's why these days we have been focusing on preventing the heart failure hospitalization and mortality related to heart failure. Not that the ASCVD events are not important, but heart failure probably assumes even greater importance. Now, what are the reasons which make a diabetes patient susceptible to heart failure? Independent of coronary artery disease or independent of hypertension, there are factors in diabetes patients which make them vulnerable for development of heart failure. First of all, hyperglycemia leads to mitochondrial dysfunction. It leads to increased oxidative stress, abnormal cardiac myocyte calcium homeostasis. In addition to that, there may be some genetic factors, advanced glycation end products, autonomic dysfunction, microangiopathy, and subclinical myocardial necrosis. We know that diabetes patients as well as hypertension patients, because hypertension is a comorbidity that is associated with diabetes in more than 60-70% of type 2 diabetes patients. So there is RAS activation. There is increased activity of the sodium hydrogen exchangers NHE1 as well as NHE3. And then there are certain metabolic derangements in the cardiac myocytes, lipid accumulation in the cardiac myocytes, lipotoxicity, lipoapoptosis, and the effect of adipokines. All these make a diabetes patient much more susceptible to the heart failure incidence as well as mortality. And that's why we need to prevent heart failure right from the word go, along with good glucose control. Not only the systolic function that is affected, the diastolic dysfunction is also very, very commonly seen in people with diabetes. The meta-analysis of 27 echocardiography-based studies have shown that about 46% of the type 2 diabetic patients have left ventricular diastolic dysfunction, and left ventricular diastolic dysfunction is also responsible for a significant increase in the morbidity as well as mortality. Never before EMPA-REG, we realized that diabetes management can actually reduce the cardiovascular event rate also. The previous studies, DCCT with intensive glucose control using insulin in type 1 showed reduction in the microvascular complications. UKPDS also was not statistically significant in reducing the cardiovascular event rate. And advanced ACCORD and veteran affairs trial actually showed other way around, that very intensive control or tight control can actually increase the cardiovascular risk. So EMPA-REG came as a real surprise. Initially, people thought that the results are too good to believe. But then the subsequent analysis and the full study literature clearly showed the advantage of this molecule, empagliflozin, in reducing the cardiovascular risk, the cardiovascular death, and overall death in type 2 diabetic patients. And this was surprisingly regardless of the glucose control. So in spite of glycemic equipoise in both the groups, empagliflozin arm showed a significant 38% relative risk reduction compared to placebo, hazard ratio 0.62, very significant p-value of less than 0.001, which means that empagliflozin plus standard of care reduced the cardiovascular risk by about 38% in the EMPIREX study. The Asian sub-analysis of this study showed even better numbers, 56% relative risk reduction in the Asian patients who were enrolled in this trial. In an Asian to diabetic patient, if you are using empagliflozin, you are reducing his cardiovascular death or cardiovascular event rate by about 56%, which is mammoth. Not only the cardiovascular death or heart failure hospitalization were reduced in patients with reduced ejection fraction, this benefit was seen regardless of the ejection fraction. You can see from the Emperor reduced trial, which was a heart failure trial in patients with LV ejection fraction of less than 40, where empagliflozin showed relative risk reduction of 25% compared to placebo. The number needed to treat 19 for 60 months. But even in patients with mid-range or mildly reduced ejection fraction, HF, MR, EF, where ejection fraction was 41 to 49%, you can see significant reduction of 29%, again statistically significant, number needed to treat 21 for 26 months. And even in the Emperor preserved, where the ejection fraction was more than 50%, there also significant benefit was seen with p-value of 0.024, that is below 0.05. Of course, the number needed to treat is higher here, 42 for 26 months. Understandably so, because these are lower risk patients compared to the high risk patients who have reduced ejection fraction. So for that matter, any molecule, if you are using it in high risk patients, will give more benefit compared to its benefit in the low risk patients. And that was consistent in this trial. In Emperor reduced, there was much more benefit. In Emperor preserved, there was less benefit compared to reduced, but still statistically significant benefit was there, even in patients with ejection fraction of more than 50%. So regardless of LV function, empagliflozin reduced the cardiovascular event rate, cardiovascular death rate, as well as the heart failure hospitalization rate, and the heart failure mortality also. Now, albuminuria, which we were talking about, Dr. Sunil very well explained that previously we never believed that from albuminuria stage you can become normoalbuminuric. You can at most come down to microalbuminuria or 30 to 300. But now with SGLT2 inhibitors and agents like finerenone, we now have evidence that these drugs also reduce the renal disease progression. But here, in patients with albuminuria more than 300, between 30 to 300, what we call microalbuminuria, now that term is no longer used, or in patients with normoalbuminuria, that means USER of less than 30, you can see the hazard ratio is to the left of the median, which means regardless of the albuminuria levels, the Emperor pooled data shows that empagliflozin reduces the risk of cardiovascular death or heart failure. We know that with albuminuria, the risk of heart failure and cardiovascular event rate is much higher compared to patients without albuminuria. But here it has been clearly shown by empagliflozin study that regardless of that, empagliflozin reduces the CV risk, CV death, and hospitalization for heart failure. So based upon these studies, now we know that empagliflozin has class 1 level A indication in patients with heart failure less than ejection fraction 40%. Mildly reduced ejection fraction, again class 1, level A evidence, ESC 2023. and heart failure with preserved ejection fraction also level 1 evidence, level A, ESC 2023. Now there is a new category, that is heart failure with improved, whose heart failure was with reduced ejection fraction of less than 40%. If they improve by 10 points from the baseline LVEF, then it is known as heart failure with improved ejection fraction. And the guidelines are now that the GDMT, including SGLT2 inhibitors, should be continued in patients with heart failure with improved ejection fraction, regardless whether they have improved and how much they have improved, whether it has improved even up to the normal range also. Still, you need to continue empagliflozin or the SGLT2 inhibitors. Now, the biggest question comes these days is which one to choose first, a GLP-1 or empagliflozin or SGLT2 inhibitor? Well, actually, there is no competition between these two molecules. Both actually complement each other and both should be combined in a given patient for the best cardiovascular outcomes. But if you like to compare, then obviously for patients with heart failure or cardiovascular death, empagliflozin has a clear edge over GLP-1 analog. This is GLP-1 analog. This is empagliflozin. The hazard ratio is 0.77. That means 23% benefit compared to GLP-1 analogs. GLP-1 analogs are also associated with benefit. We now know from the SOUL study also that even oral semaglutide has cardiovascular as well as heart failure benefit. But empagliflozin, the benefit is definitely much more. This is not a head-to-head trial comparison, but the analysis from the different studies, especially EMPRISE, have shown a benefit in favor of empagliflozin compared to GLP-1. From atherosclerotic event, probably both are same, EMPA and GLP, but from heart failure, obviously, and for heart failure and CV death, empagliflozin has a clear-cut edge. With this, I will stop here because we'll have a very healthy discussion